Coming to question number 42 of previous year NEET PG question series. This is a 2023 neurology question. So what may be the probable diagnosis? A male patient presents with sensory loss and weakness of both lower limbs for the past 3 months. He is a chronic alcoholic. On examination, he has UMN type of paraparesis, absent ankle reflexes. Sensory examination showed loss of proprioception, loss of vibration. Pain perception was present. What may be the most probable diagnosis? So let's note down the clues and dissect this question. So there is a sensory loss and weakness of both lower limbs. Weakness of both lower limbs is called as paraparesis. So there is paraparesis plus there is some sensory loss. This is present for the past 3 months. So it is not an acute disease, it is usually a chronic disease. In neurology, acute is always vascular event. Acute is always vascular event, that is stroke. So this is not an acute event, it's present for the past 3 months. So it has to be either degenerative or nutritional or toxic. That is the clue here. He is a chronic alcoholic. So alcoholic means definitely there is some nutritional or a toxic problem. Okay, now on examination he has UMN type of paraparesis. Before that, what is the site of localization of paraparesis? In neurology always, whenever there is a finding, we should try to localize what is the part. Only then we should think about the etiology. So paraparesis localizes to the spinal cord or the nerves which come from the spinal cord. We know that hemiplegia or hemiparesis comes from the brain, that is upper motor neuron, corticospinal tract above the spinal cord. Hemiplegia or hemiparesis is invariably the brain. You just think like that, brain. What is crossed hemiplegia here? Crossed hemiplegia is ipsilateral cranial involvement and contralateral hemiplegia. Here the involvement is in the brainstem. Okay, so paraparesis means spinal cord or the nerves which arise from that. That is the localization of paraparesis. So we are dealing with some spinal cord disease. Now thinking of the pattern of weakness, there is UMN type of paraparesis. Now what is UMN weakness? What is LMN weakness? So very well discussed in the clinical aspects in final year. Upper motor neuron, what happens to the bulk? Bulk of the muscle will be normal in UMN. Bulk will be reduced in LMN. So that is called as wasting. There will be wasting of muscles in LMN lesion. What is UMN? What is LMN? The corticospinal tract is upper motor neuron. That is the fiber starting from the brain up to the anterior horn cells of the spinal cord is called as upper motor neuron. From the anterior horn cell of spinal cord till the muscle, it is called as lower motor neuron. Right. So bulk is normal in upper motor neuron. Bulk is reduced in lower motor neuron. What happens to the tone? Tone is increased. That is, tone is spastic in UMN. Tone is flaccid in LMN. What happens to reflexes? Reflexes are increased or exaggerated in UMN. Reflexes are absent or reduced in LMN. So everything is reduced in LMN, everything is increased in UMN. Then we have the plantar. Plantar will be extensor in UMN. The Babinski sign will be positive in UMN. Plantar will be flexor in LMN. So this is our basic difference. So if it is an UMN type of paraparesis, bulk has to be normal, there has to be weakness, spasticity, reflexes has to be exaggerated, plantar should be extensor. Now there are few conditions where there is mixed upper motor neuron and lower motor neuron findings. For example, one combination is there can be wasting, there can be flaccidity, that is tone is flaccid. There can be plantar extensor, but reflexes are exaggerated. So this combination you can see 2 LMN findings and 2 UMN findings. There can be another combination where bulk is normal, there is spasticity, plantar is extensor, but reflexes are absent. So here we have 3 UMN signs and 1 LMN sign. So there are many causes for this mixed UMN and LMN findings, but for at least exam sake, think of only 2 diseases. That is wasting, flaccidity, but if the reflexes are exaggerated, that disease is amyotrophic lateral sclerosis. It is a motor neuron disease. It is a motor neuron disease. So the motor horn cells of the spinal cord is affected. The motor horn cells of the spinal cord is called as lower motor neuron. The motor neurons from the cortex, that is the beginning point of corticospinal tract, is called as the UMN, upper motor neuron. So in ALS, so both upper motor neuron and lower motor neuron are involved. That is why ALS is a motor neuron disease. We have mixed of these 2 findings. Now, where does this finding occurs? Normal bulk, the spasticity, extensor plantar, but absent reflexes occurs in subacute combined degeneration of spinal cord. Subacute combined degeneration of spinal cord is a spinal cord disease which occurs in B12 deficiency. So why every finding is UMN? Because every finding is UMN because the corticospinal tract is affected in the spinal cord. Right? The name itself suggests combined degeneration of spinal cord. So the corticospinal tract of the spinal cord is affected, so we get UMN findings. But it is combined. What is combined? The nerve is also affected. I told you anterior horn cell or its underlying nerve is LMN. So when the nerve is affected, it causes loss of reflexes. Right? So mixed of UMN and LMN finding in B12 deficiency is because of involvement of corticospinal tract and the nerve which arises from it. Okay. So that is what we get here. So he has UMN type of paraparesis, but there is absent angle reflex, which is an LMN finding. So nerve is affected, causing absent angle reflexes. UMN type of paraparesis means he has spasticity, normal bulk, and extensor plantar. And sensory examination showed loss of proprioception, loss of vibration. In sensory, we have 3 tracts, right? The dorsal column or the posterior column. Then we have the anterior spinothalamic tract. Anterior spinothalamic tract. And we have the lateral spinothalamic tract. So all these tracts carry sensations from the periphery to the brain. Dorsal column is needed for vibration, proprioception, position sense, and also fine touch. Anterior spinothalamic tract is for crude touch and pressure. Lateral spinothalamic tract is for pain and temperature. Remember subacute combined degeneration. So combined is in motor, there is combined degeneration of cord as well as the nerve. It also can be taken as there is combined degeneration of the dorsal column as well as the motor. So sensory and motor both are involved. So dorsal column is the one which is affected in subacute combined degeneration of spinal cord. So they are given there is loss of proprioception, loss of vibration, but pain perception was present, which means lateral spinothalamic tract is intact, but only the dorsal column is involved. So all these findings point towards that there is a subacute combined degeneration of cord. Why not the other things? Extradural cord compression. Even though you are not sure what is this, when cord is compressed, maybe these things will be discussed in orthopedics. When the cord is compressed completely, everything has to go, right? The anterior part of the spinal cord is for motor, the posterior part is for sensation. That is what is our basic physiology. When the cord is compressed, the entire part of the spinal cord has to affect. So both the sensations has to go. So all the sensations has to go. It is not selectively the dorsal column. All the sensations, which means lateral spinothalamic tract, pain and temperature has to go. The anterior spinothalamic tract, that is crude touch and pressure has to go. Dorsal column, that is vibration, joint sense, position sense, proprioception and fine touch. Everything has to be lost. Motor has to go, right? And autonomic has to go. Plus there must be a level. When cord is compressed, there should be a particular level above which everything is normal, below which everything is abnormal. So there has to be a level in cord lesions. So there is no level which is given, right? And there is selectivity of involvement. So cord compression or other spinal cord diseases is not likely. Amyotrophic lateral sclerosis, I told, it is a motor neuron disease. It is a degenerative disease. So a degenerative disease will not last for only 3 months. It should be lasting for a longer time. Plus, of course, it also has human and element findings, but the combination is there is wasting, there is weakness, but there is exaggerated reflexes and plantar extensor. So this combination does not hold here. Plus, motor neuron, this amyotrophic lateral sclerosis is a pure motor neuron disease. It doesn't involve the sensations, right? So what are the diseases in neurology which are pure motor involvement? One, motor neuron disease, obviously. Whether it is upper motor neuron or lower motor neuron, only motor has to be affected, sensory will not be affected. So one is motor neuron disease. So we have a classification of motor neuron disease, purely UMN disease. Example, primary lateral sclerosis is a purely UMN disease. We have purely LMN disease. Example, spinal muscular atrophy is a purely LMN. Why spinal muscular atrophy? Spinal cord is a lower motor neuron. Then we have UMN and LMN. The example for that is ALS. ALS is most common among this. The next neurological disease with pure motor involvement is neuromuscular junction disorders. Polio is also a lower motor neuron disease. If you ask to remember, then neuromuscular junction disease we have myasthenia, where there is acetylcholine receptor antibody. In some cases, we have MuSK antibody positivity. It is an autoimmune disease associated with thymoma. Close DD for myasthenia gravis is LEMS, Lambert-Eaton myasthenic syndrome, where in tumors such as small cell cancer of the lung, there is paraneoplastic secretion of antibodies. Those antibodies damage the voltage-gated calcium channels in the presynaptic membrane. Myasthenia is a post-synaptic problem. Lambert-Eaton myasthenic syndrome is a presynaptic problem. The third disease with pure motor involvement is muscle diseases. So muscular dystrophies like Duchenne's muscle dystrophy, Becker's muscle dystrophy, etc. or myopathies. So muscle diseases. But here there is a sensory problem which is given, so definitely it is not amyotrophic lateral sclerosis. What is multiple sclerosis? It is also a subacute chronic disease where there will be relapsing remitting pattern. Practically any neurological sign can be involved in multiple sclerosis. This could be multiple sclerosis, but they may give some other features like optic neuritis, right? The history may be relapsing remitting, but from the history of alcoholic, short duration, plus this combination, subacute combined degeneration is more likely. Okay. There are only some diseases which involve only the dorsal column of the spinal cord. So dorsal column diseases. One is subacute combined degeneration of spinal cord. Then we have tabes dorsalis, that is syphilis. Here copper deficiency, zinc toxicity, nitrous oxide toxicity which occurs in deep divers. Okay, there are some other reasons, at least remember these diseases. These are pure dorsal column diseases. Think of subacute combined degeneration of spinal cord in B12 deficiency and tabes dorsalis in syphilis.